So patient-centered research. That's okay, sorry. So patient-centered research. So Martine, and this full credit to Martine, I've done none of this work at all, right? So Martine and PSC Support did this work, right? And we're in the process of trying to write it to submit to one of our medical journals so other PSC doctors can read it. Now, we're mindful that doctors may have different priorities for research than patients do and that caregivers do. And based on that, Martine conducted a survey in 2016, I think it was, just to see what the biggest concerns are for patients and caregivers. And one of the big surprises to me, actually, and many others, was the emotional burden that PSC has, mainly around the uncertainty. Will I develop cancer? Will I need a liver transplant? Many questions of which you've asked me today. And somebody's alluded to the fact that I'm not getting annual colonoscopy, I'm not getting annual ultrasounds in my local hospital, that variation in practice. Some centres do 6 monthly MRI scans. If you're in Finland, you'll get 6 monthly ERCPs. And does that difference in practice make a difference to how you do? Symptoms was a big component, as you'd know, and mainly around fatigue, around sort of the energy. And sadly, there are some people around who don't believe fatigue in PSC is real and think that only other liver diseases get it. And that's a real bummer. But this data shows that symptoms are a real burden. So what can we do? Well, in PBC, so Jennifer, who's sadly had to go because she's got an exam, our specialist nurse who we kept on pointing to, so he started a program of exercise intervention. And it's based on this particular bit of data. In PBC and PSC, we've shown one of the reasons individuals get fatigued is because when you move, the acid levels in your muscles don't go back to normal once you stop moving. The Newcastle group, led by Professor Jones, who works for the Department of Health now in various capacities, they did an exercise intervention study where certain types of exercise, so you can do all the 10Ks you want, you can do all the weights you want, but certain types of exercise get rid of your fatigue in this liver condition. And one of his research fellows, who's now a consultant there, has shown that the fatigue in PSC has a similar mechanism. So what Jennifer and our physiotherapy colleagues are doing now, and it is only funded for PBC at the moment, but it will extend to PSC very soon, is using that same exercise intervention to improve the quality of life of individuals with PSC. Now, we're mindful that some people, I think there's somebody here from Pembrokeshire, can't come here weekly for our physiotherapist, our nurse, and our personal trainer to say, right, how much have you done? It's not, it's not practical. So what the funding has allowed us to do now is say, right, we will start you off, our personal trainer will meet with you, our physio will meet with you, determine what physical activity and exercise you're doing, and the level of fatigue you've got. They will then prescribe you, this is a prescribed program of graded exercise to get your fatigue better. We will give you a Fitbit, not to sell on eBay, but a Fitbit, you can't see the screen, but we can see what you're doing, and we can monitor to ensure that you're keeping up with what we tell you to do, and it is telling you, so it's a bit of a sort of teacher-student thing, and I'm sorry for wording it that way, but that is exactly what it is. And we will then monitor you, how your energy levels are. Now, I can't tell you whether it's working or not yet, but out of the 6 or 7 patients we've enrolled, all of them have got rid of their fatigue, absolutely. Okay? So if we can translate that to PSC from PBC, that would be brilliant, because some of the mechanisms overlap. So we're trying to do that. But the main endpoint is improvement in quality of life, driven by the fact that fatigue is the biggest burden on symptoms. So what can we do for PSC? So we've talked about what we can offer and what we can't offer, and there is no medicine that takes PSC away or that is proven to slow disease progression in everybody. But we do have clinical trials. Now, clinical trials, people say, oh, I don't want to be a guinea pig for them. It's not practical for me to come here for visits. And there are different stages of them. And I think it's important to outline those stages so people understand the importance of coming to a specialist centre. So phase 1 clinical trial, so this is for, if you have a common disease, you can get the sort of patient's number. But in a rare disease like PSC, we have to divide everything by 10, all right? And in a phase 1 early phase study, all we look for is safety. So somebody talked about trials of fecal transplantation. That's what stays there in phase 1 to 2, looking at safety. The next thing is efficacy. Does it work? Are there any early signs of how it works? So any suggestion? So weak evidence of a positive effect. When we go to phase 3, that's the stage before a drug can get licensed. That's literally the sort of, the last, the exam of, right, is it going to make the cut? Is it going to break through as a treatment? And then you need a strong evidence of a positive effect. But both of these need to have what we call a placebo arm. So some groups take the active treatment, some take a dummy pill. And it's really important to know whether the improvements we see are actually due to the drug or just variation. I will say one thing, almost all trials in my experience which have shown some positive effect, they give everybody with a placebo the active drug afterwards to ensure that it has a continual effect. So everybody will get a fair chance at getting a treatment. So active drug, dummy drug. The dummy drug people will then get moved to the active drug later on anyway, if there is a positive effect. So it's not that you're going to be a guinea pig and you're only going to ever be exposed to the dummy drug. You will be given a chance to have the active treatment. Okay, so let's talk about early stage trials. So University of Birmingham, the head of our liver research group is Professor Phil Newsome, and his interest is in modulating your immune system by giving you cells that you already make, but we manufacture them in a lab and we give you more of them, okay? So we've started this particular study called Merlin, and we give you a cell type called MSCs that restore the immune balance. And in mice with PSC, we managed to get rid of it by giving it to them, which is great. And we're now trying it in sort of you, the patients. And what we are trying to do is restore the immune balance that's caused your PSC and your colitis in the first place. And it's now at a very early, well, it's actually past the early stage, phase 1. It's now at the phase 2 stage of looking for early signs that it's improving things. We've already shown that we can cure it in mice. We're now trying to show it cures it in humans. People talk about URSO, and I will mention URSO in a moment. There is a slightly modified version of URSO called NorUrso. James talked about bile recirculation. This particular molecule stays around a lot longer in your bile ducts and in your liver. It goes round and round rather than going all the way through the gut. And the effect of that is it protects your bile ducts for a longer period of time. And we've seen normalization and improvement in liver blood tests in a phase 2 trial, so the middle stage trial with this particular drug. The reason that this particular trial is attractive, well, the first thing is it's the first trial in over 10 to 15 years in PSC. Yeah? So it's taken us that long to get a drug to show some improvement. We've used drugs for PBC in PSC, so there is a drug called OCA, and we see the same effect in people taking OCA, a huge reduction in alkaline phosphatase in that particular blood test in our patient groups with PSC. But alkaline phosphatase as a blood test is not necessarily the only marker that we want to see in patients. The early studies of ursodeoxycholic acid, about half the people did improve their alkaline phosphatase. But we then came to know that by improving alkaline phosphatase, that doesn't mean much because people taking URSO at higher dosages had much bigger improvements, but they were more likely to need a transplant or die in the end. So URSO has no survival benefit, does not prevent the onset of transplantation in PSC. It does improve blood tests in some people, but it doesn't prevent what we call the hard endpoint, which is why we need the bigger trial, which is why we need things more than just measuring blood tests. Right, we are now in the stage where those sorry, go on.
Sorry, so should people be routinely taking URSO?
I do not start URSO on anybody. If somebody comes to me with PSC and they're on URSO, if they're tolerating it well, I have no problem if they continue it, as long as the dosage is not the higher levels that cause problems.
What is the higher level?
So it's based on weight. So certainly anything above about 22, 23 milligrams per kilogram in a day is too high, and I don't let people take it because it's dangerous. If they're on lower levels and they feel very comfortable about taking it and they're not having problems, I don't push them to stop it. But I don't start anybody on it because it makes, I'm happy to say this, there is no survival benefit or no benefit of taking URSO apart from some blood test improvement in a tiny proportion of patients.
Yes, I do.
Yeah. The other reason is that
Why do I take it then? Why do I take it? I don't understand.
because in some people, when they started on URSO, there was, it says, right, it might improve your blood tests. And people accept the improvement in blood tests as doing better. And that's not acceptable. So that's why I don't say you should stop URSO if you're comfortable taking it, but it's as good as taking a placebo.
I don't know. Sorry, I'm very confused.
Put on URSO.
Yeah.
And I think he's worried that if he doesn't take it, the doctor will think, oh, you're not complying, why should I bother with you?
No, I know. And I'll come on to that. Sorry, let me just answer that. Yeah, I'll come on to that very point actually next.
I asked that question in Oxford when I was looking at
Can I ask when, just before you continue, when did you ask that question?
Within the last 3 months. 'Cause
Right.
I'm
Yeah, sure.
on NorUrso for a year.
Yes, yes.
I asked the question about URSO, and I was basically told that, you know, like you said, it improves blood results, but it
In some people, yeah.
slowing
Yeah.
down my fibrosis. However, I'm from a family that has colon cancer in the family, so I was told to carry on taking it because there was some evidence of protection
Yeah.
against colorectal cancer for my particular circumstances.
Yeah, so that's a very good point. So there were very early studies. In fact, some of these earlier trials, when people were taking URSO, they thought it might reduce biologically the chances of cancer. We now know through bigger groups of patient data, when we look at all that, it doesn't necessarily reduce, it doesn't reduce the risk of cancer, it doesn't reduce the time to transplantation, and it doesn't reduce the chances of dying from PSC. It does improve liver blood tests in some group, but that doesn't equate to the longer term measure.
An anecdote, I stopped taking URSO for the Merlin trial, and I had an initial period where, as with any major medicine change, I tend to feel worse. And after that, I felt pretty much the same after it as I did while I was on it. The difference being is my blood test results are now, I think, more reflective of how I feel. So I always had this disparity when I came into clinic that
Yeah.
I found
So-
terrible, but my blood test results were quite good. And now, no, I'm not on the URSO, they're all sort of more where I think the doctors think they should be. And the only slight annoyance, I guess, is my eyes have gone slightly yellow because the bilirubin's gone up
Yeah.
a little bit.
So my concern about URSO is that a lot of people are taking it thinking that they should be taking it. And that sometimes prevents them either being enrolled into a trial that may test a real difference. The other thing is that some clinicians view it as a bit of a puncture repair kit. So if you have a puncture in your tyre and then you fill it up with air, your tyre pressure is going to be normal for a time. That top up and the continual top up may mask a bigger problem. And we did see in those trials that with URSO deoxycholic acid, at certainly at higher dosages, we saw more colon cancers, we saw more people who needed to have a liver transplant, and more people who were succumbing to their PSC. The middle dosages of URSO, the sort of doses where, again, when I say weight-based, around about 15, 17 milligrams per kilogram per day, that sort of safe dosage, yes, some people still have reduction in their blood tests, but that doesn't mean it's going to make a difference longer term. Yeah? That's what I want to say. Now, these early phase trials, which only look at an improvement in blood tests, the same as URSO did, the reason that we need to see whether they actually have a real effect is because without that, we will never have a cure for PSC. And a cure for PSC is something that we all want. Now, I'll give you an example. Mark mentioned the Merlin trial. In a 3 to 6 month period, we found 62 eligible patients who were coming to a clinic regularly. So we have about 200 patients who haven't had a transplant in Birmingham, about 62 who were seen in that period, about 3 to 6 month period, who were eligible for Merlin. So there are certain eligibility criteria that every trial will have. Things like your colitis has to be well controlled. You can't be currently having a flare of your cholangitis. Every trial is slightly different, but 62 patients met it. Only 3 patients agreed to go into the trial. Now, I'm not saying you must do a trial. That's unethical, and that is not sort of in myself. But if we are to ever find a cure for PSC, then some of the drugs that have shown real benefit and actually cured it, yes, in animals, as I mentioned. So NorUrso can get rid of PSC in a mouse. But if we're going to have a real chance at cracking it, this is the time. We are now going to have at least 3 phase 3 studies in PSC. 3 phase 3 studies in PSC. And if we don't recruit to these particular trials, we will never find a cure, ever. Sorry, yes, go on.
I'm on my 5th, I think, now, and I would definitely say to anybody to give them a go. They look after you really, really well. Some don't work out. FNA study was, uncomfortable, it was pinch. But the, I can't get the words out, but the oversight and the scrutiny that they put into these trials and the care that they give you is outstanding, and you get a much better view yourself as a patient about what is actually happening to you. So, I may well have 3 MRIs a year and ultrasounds every 10 weeks and fiber scans every 12 weeks or whatever. But you really do get a better view of what's going on, and the rigour around the trials. It's nothing like that scary thing years ago when people's heads exploded. It's really, really not like that at all.
And so,
Definitely recommend to anybody to participate in trials.
Just one of the things about trials is that they will always, fund all your clinic visits, of course. And Martine actually is the person who's now trying to get some of the newer trials to actually fund childcare, if that's going to be an issue as well. And the reason I'm keep on harping on like a broken record is because if we fail to prove it works, not because there is no drug effect, but because we just can't get enough people to prove it works, then we'll never get anything. And some of these drugs are showing real promise, and I can't give away too much, but we just need more of you to help. So the 3 things I mentioned. So the first thing is, on the PSC Support website, Martine will put all the trials that are currently active and which centres are doing them. And I may regret this in the future, but anybody who wants to know about PSC trials that we're doing in Birmingham, Martine will give you my personal email and I will tell you. All right? Okay, so, and that is all, it's on Facebook, I think, isn't it? My personal email address, right? And email it, yeah. So it's there. So yes, by all means, you can contact me and I will let you know. That's the second way. And the best way of knowing is if you join UK PSC. So UK PSC works with PSC Support, and it's an investigator initiative to have everybody who has PSC, we can monitor where you are, not in terms of like a big brother watching you, but you can tell us how your symptoms are year on year. We can keep tabs as to whether your disease is getting better or worse, and it's all anonymized to sort of apart from to the data team. And anytime there's a trial, we have a project manager and a data manager that their sole purpose is to screen the database, saying right, you sort of Joe Bloggs, you're eligible. I don't know, no one's called Joe Bloggs here. You're eligible for this particular trial. You're part of UK PSC. Would you like to take part in it? And that's.
How is that contact made? Do you write? Have you got a mailing list? That's what I'm asking.
Yeah. So if you're part of UK PSC and you're eligible for a trial, then you will get sent an invitation. The second thing is anybody who's not in one of the transplant units. And if you're not in a hospital that does a PSC trial, it is an NHS mandate. The NHS Charter says it is your God-given right to take part in a trial, and your clinician, be it your hospital doctor, your GP, can make a referral to the local centre to take part in the trial. That is in the NHS Charter. So it is your right to take part in it. Can be better, but awareness of what's currently going on, PSC Support, UK PSC website, and all the social media channels should have. I don't know if you want to add anything to.
We have the trials on our website, but I think we're a rare disease. We're not all seen in hospitals like Birmingham, and obviously some of the research nurses are not the best communicators. So it is up to us to be proactive. Look what research is out there and ask the doctors.
Yeah.
Something about maybe the problem
No, I know.
Falling over themselves to pay you. Actually, and Maxine and I we're writing a survey at the moment, and it's thanks to people like you that fill in our surveys that help us change things. And we want to find out, like, what would make it easier for you to go on a trial? What do the researchers, the pharmaceutical companies need to do to make it easier? Is it you have your study day on a Saturday? Is it that you have your childcare paid for? Is it the car parks and taxis arranged? Is it something else we've not thought? What can we do to make it so people can get on trials?
To know which trials are going on, by all means, check the website, the social media pages. If you can get in touch with, if you want to come here, by all means, me or the other trial sites will have their own email address if they're closer to you. And certainly, all we would need here is either a letter from your GP or your local consultant, just to say I've got sort of this person who has got PSC, and they are aware and would like to be considered for this particular trial. What do you think? And then I can make an appointment if need be, and then see you accordingly.